Bueno, para que no ocupar más tiempo de esta actividad, por último solamente quiero destacar, según el video, creo que podemos entender, en los últimos años Mandarin ya ha logrado mucho éxito. Creo que el secreto de este tipo de desarrollo sería la tecnología. Como mencionaron, tenemos 10 centros de investigación y desarrollo, 6 en China, 1 en Europa, también hay 3 en Estados Unidos, en Seattle, New Jersey y en Silicon Valley. En este caso, cada año nuestra gente estamos en estos países para hablar con los doctores, para conocer no solamente su retroalimentación de nuestra solución, de nuestro servicio, sino también su demanda clínica, potencial y futura. Así que la reflejamos a nuestra casa matriz para desarrollar nueva tecnología para nuestros próximos productos. Porque sabemos que anualmente en Mandarin invertimos más de 10% de nuestros ingresos anuales para el desarrollo e investigación. Por eso, creo que eso debe ser el secreto. Por otro lado, nuestra plataforma también es más importante para este tipo de desarrollo. Justo este año, hace 2 meses, se inauguró nuestro sucursal Mandarin Chile en las Condes de Santiago. El objetivo es que podemos trabajar más estrechamente con nuestros partners, por ejemplo, Ecografía con Datamedica, para dar mejor soporte y atención a ustedes, a los clientes finales. En este caso, en el futuro, cualquier necesidad de ustedes, estamos junto con nuestro partner a la disposición. Que disfruten de esta actividad de hoy. Muchas gracias.
Muchas gracias, Juan Liu. Lo vamos a volver a ver cuando sorteemos un ecógrafo en el Coffee Break. Una vez dicen que sí. Ya. Exactly. Audio. Oh, we don't need audio. If you use presentation mode. Zoom slideshow. That's funny. Is it doing it? Si no improviso algo sin PowerPoint, no hay problema. ¿No? Ahí viene. Ahí sí. Ya, ahora sí una pequeña introducción para iniciar el curso. Desafortunadamente no tengo conflictos de interés. Y los contenidos de la introducción, vamos a hablar un poco brevemente de la estructura del curso, de la figura de Christian Doppler, del efecto Doppler y ultrasonido Doppler. Este es un curso teórico práctico, hands-on, como le llaman en el mundo angloparlante, que es fundamental en ecografía. La verdad es que un curso de ecografía sin tener el transductor en la mano, sin ensuciarse con gel, la verdad que no es una experiencia completa, dado la naturaleza de esta modalidad. Y ahora que hemos vuelto a realizar actividades presenciales, para nosotros es un agrado poder volver a hacer un taller que tiene un componente práctico. Contamos con 7 profesores del mundo académico, público y privado, destacando la presencia del doctor Dajilla, quien ha viajado desde Arizona, en Estados Unidos, a acompañarnos, desde la Clínica Mayo de esa ciudad. Además, los pasos prácticos van a contar con una diversidad de equipos de distinta gama del auspiciador Minray. Vamos a tener 9 clases expositivas y 4 horas completas de talleres prácticos, lo que es un porcentaje muy bueno en relación al tiempo del curso. Una de las cosas que muchas veces no saben las personas que están entrando en el mundo de la ecografía es de dónde viene la palabra Doppler, ¿ya? Doppler es un apellido de este señor que es Christian Doppler, y por eso siempre Doppler hay que escribirlo con mayúscula, porque es un apellido. Doppler es un físico y matemático austriaco que nació en el año 1803, que estuvo trabajando en varias universidades alrededor de Europa en esos años. Los gallos más brillantes, como que decían, era como los equipos de fútbol. Están 2 años en una universidad top, después iban a otra universidad top en otro país y daban vueltas por Europa. A los 38 años, él describió por primera vez lo que después se conocería como el efecto Doppler. Así que los que ya tenemos 38 más, si no hemos hecho algo igual de importante, yo creo que ya no lo hicimos. De los datos curiosos, fue profesor de Gregor Mendel en la Universidad de Viena. Era habitual en aquellos años que todos los gallos más o menos famosos tenían algún grado de interacción e vinculación entre ellos en Europa. Y otro dato interesante, que si ustedes leen libros sobre ecografía, los prefacios, etcétera, o publicaciones, en muchos lugares lo llaman Johann Christian Doppler, pero eso es un error histórico que alguna vez alguien puso en un libro y se siguió replicando en el tiempo. Pero no se llama Johann, se llama Christian Doppler nomás. ¿Ya? Esa es una... él vivió y trabajó en muchas partes de Europa. Esa es una placa que está en su casa en Praga, en República Checa, así que si van para allá, van a visitar la casa donde vivió Christian Doppler. Se fijan que no dice Johann, es solo Christian. Y ese es el paper donde él comentó este efecto Doppler, que inicialmente fue un fenómeno astronómico. De hecho, el paper se llama sobre la luz coloreada de las estrellas binarias y algunas otras estrellas de los cielos. Ya no son tan poéticos los títulos de paper. Y se fijó que las estrellas que se acercaban a la Tierra emitían luz en el espectro rojo y las que se alejaban emitían luz en el espectro azul. Entonces cachó que dependiendo en qué dirección se movían cambiaba el espectro de la luz. Y ahí nació la idea del efecto Doppler. Y por eso nosotros ahora tenemos trabajo. En Venecia, ya que por lo menos pre-pandemia nos gustaba tanto viajar, esa foto que ven ahí es la isla de Venecia, ¿ya? Y donde está el marcador de ubicación, acá arribita, esa pequeña isla se llama Isla de San Miguel y es un cementerio, un tremendo cementerio, súper grande. Lo único que hay en la isla es el cementerio, ¿ya? Ahí está una foto, ahí es donde uno se baja en el botecito para entrar al cementerio. Y en el cementerio de la isla de San Miguel en Venecia está enterrado Doppler. Así que si ustedes van a Venecia y trabajan haciendo ecografía Doppler, van y le dejan una florcita porque nos ha ayudado bastante. Venecia está enterrado Doppler. El efecto Doppler, el resumen más simplificado posible, dice que la frecuencia de una onda depende de la velocidad relativa entre la fuente que emite la onda y el observador de la onda. Más detalles de eso vamos a ver en la clase después del doctor Dajilla de los principios físicos. Pero eso es el efecto Doppler. Si, como pregunta de prueba para los residentes, ¿qué es el efecto Doppler? Esta sería la alternativa correcta. El efecto Doppler no solo forma parte de nuestro trabajo como imagenólogos, sino que forma parte de nuestras vidas en otros aspectos. Por ejemplo, la detección de submarinos a barco, de barcos submarinos, también se basa en el principio del efecto Doppler. Cuando Carabineros de Chile mide la velocidad, también utilizan esos dispositivos que utilizan el principio Doppler. Algunos radares meteorológicos utilizan el principio Doppler y nosotros también con la ecografía Doppler. Una cosa que se escucha con mucha frecuencia entre las personas y los colegas, a veces los colegas clínicos que no están tan metidos de esto, es que dicen que el Doppler mide el flujo. Eso, estrictamente hablando, es incorrecto. Y es importante entender por qué es incorrecto para comprender mejor el funcionamiento del Doppler y hacer un mejor examen y una mejor interpretación. Lo que el Doppler mide es frecuencias. Eso es ecografía Doppler, medición de frecuencia. La diferencia entre las frecuencias medidas se traduce en movimiento, debido al principio del efecto Doppler. Y si ese movimiento tiene una dirección y velocidad determinadas, nosotros lo interpretamos como un flujo. Pero así es como pasamos del Doppler a decir que hay tal velocidad de flujo en la sangre. Porque es un movimiento y que ese movimiento que medimos con la frecuencia está sujeto a una interpretación de nuestro cerebro y logramos decir que ese movimiento constituye el flujo vascular. Así que muy bienvenidos y vamos a partir ahora con lo importante. Voy a dejar con ustedes al doctor Nirvi Cardajilla. El doctor Nirvi Cardajilla es jefe de ecografía de la Clínica Mayo de Phoenix, en Arizona, y además es profesor titular de radiología en la Clínica Mayo. Es un gran honor para nosotros contar con su valiosa experiencia en este curso. Así que saquemos provecho de sus clases. Nos trae varias cosas que son nuevas. Hay nuevos criterios diagnósticos, por ejemplo, en carótida, nuevas velocidades. La verdad es que me he tenido que poner al día en las conversaciones con el doctor Dajilla, así que saquémosle mucho provecho. Y sin más, doctor Dajilla, lo invito, please, Nirvi, you can come to start your lecture. Así que muy bienvenido y que aprovechemos mucho este curso. Gracias.
I have to use both or one? This is okay? So let's see. What did he try? Yeah, what did he try? He tried the function. Function. Okay. All right, thank you, Eugenio. That was an excellent introduction. It makes my work very easy, because that Doppler introduction was very nice. I have some similar slides. Anyway, good morning, everyone. I'm glad to be back here. This is my 4th trip to Santiago, and always a pleasure to meet old friends and make some new friends. I worked in India for many years as a radiologist and moved to US in 2005. Then I worked as a radiologist in Malincrot for some 8 years and moved to Mayo Clinic in 2013. Just for people who may not be aware, there are 3 Mayo Clinics. The big one is in Rochester, Minnesota, and then we have one in Arizona and one in Florida. To understand the size of the clinic, the size of Arizona clinic is 10% of the size of the clinic in Rochester. So this is a huge enterprise. In Arizona, we have about 55 radiologists in one place. So we do all CT, ultrasound, MR, everything. A big new artificial intelligence division. My division has about 25 ultrasound machines, 42 sonographers, and we do almost everything except OB ultrasound now. These are the Mayo brothers, the visionaries. More than 100 years ago in Rochester, they started this Mayo Clinic. Of course, now they're wearing a mask. These are the times of today. This is the clinic at the Arizona campus, and this is the new building, which is the cancer wing. This is a separate building, not here. This is the medical school and the outpatient setting. And then we have opened a new center for advanced medicine. If you look at this building, already we have started constructing another tower on this side and another tower which is going to come here. So it's already expanding fairly fast. This is the view which it will become. So if you see this building, there's nothing here, but this building's already started coming. This is the new ER, and then this building is going to go all the way up. So we've invested about $600 million for expanding the Mayo Clinic in Arizona. Arizona is getting a lot of patients from California, from New Mexico, from Gulf, Canada. So I know Eugenio has a lot of interesting ways, and in some ways he reminds me of myself 20 years back. I did my first Doppler workshop in Sri Lanka, in the city of Colombo, with the Sri Lankan Radiology Association almost 20 years back. So when I start my lecture or teaching my residents, I always think that we should tell a story, right? So Doppler has to be a story. And every Disney movie you have seen, it always starts with Once Upon a Time. So we'll start with Once Upon a Time, and there is always a prince. So there was a prince. Now in this case, this prince was riding a horse, and after a battle, the prince was coming to meet, a princess. So this is a classic story, right? The only interesting concept here, which I wanted to highlight, is that between the prince and the princess, in good old days, there was no texting. Nobody could text a message. The pigeon had to fly. So there was this pigeon which was taking a scroll of message. Every day the prince will send a message to the queen, keep riding, next day again. And the queen is thinking that the prince really loves me because every day the message comes faster and faster and faster. It comes earlier than the day before. And in one way, that is what Doppler shift is all about. If you think about it, if one structure is stationary and the second structure is moving towards that structure, then the frequency keeps going up. And that is a classic positive Doppler shift. The same thing, historically, people always tell about this story with ambulances, right? If you are standing and the ambulance comes towards you, the sound goes up. If the ambulance goes away from you, the sound goes down. So when it goes away from you, decreasing frequency. So anything in Doppler, when you put on a graph, you draw a line, and anything above it is positive Doppler. Anything below that is a negative Doppler shift. And this is all the Doppler concept is about. In old days, proving science was much easier than today. Today it's very difficult, right? Anyone who does research understands it's very difficult. In old days, there was this guy, a Dutch scientist, Biusbello, who came after Doppler himself. And he had to prove this Doppler effect. So he went to the Vienna Opera House, and he took two trumpeters, they play the trumpet on a certain frequency. And he put one of them on the train station and the other one on the locomotive, on this engine. This is the exact engine he used. I took the picture from the museum. And then he made this engine go away from the station as the trumpeter was blowing and brought it back. And the first trumpeter said to the second one, "Why did you keep changing the frequency?" And the first one said, "I never changed the frequency." So that was the first science experience to say, oh, there is something called Doppler shift in sound. And that is what we started using. You already know by Eugenio showing this image and the first paper. The interesting thing is that this paper, which Doppler presented himself on the Doppler shift related to light of stars, that big paper, which has changed all our lives, in that conference, Only 5 people attended that conference. So you can understand that big things can happen, even though there is nobody listening to me. I'm already feeling happy there are more people here than people who listened to Doppler in 1845. This is me 20 years back at the Doppler Museum, and that is Eugenio 20 years later at the Doppler tomb. So between the two of us, we have gone to the birthplace and the death place of Doppler. So obviously, there is a friendship because of Doppler between us, and I hope it extends further. In the simplest term, we are dealing with Doppler shift. That is the difference between the frequency of transmission and the frequency of receiving. That's it. Now, when the observed frequency is more than the source, positive Doppler shift. When the observed frequency is less than the source, negative Doppler shift. The same thing happens with blood vessels, right? RBCs, red blood corpuscles, are flowing in the blood vessels. And when sound hits them, if they are moving towards the transducer, positive Doppler shift. If they are moving away from the Doppler, then it is negative Doppler shift. This whole thing goes down to one equation. Now, you don't need to know the equation because the machine does everything. But it's important to know there is one equation that defines the entire Doppler concept. You know, when I gave the American Board of Radiology exam, I met this examiner who was telling me the story that when a resident used to come for the oral exam, they are shown 15 ultrasound cases and they have to get 10 right and then they pass. And they go to the next one, 15 neuroradiology cases. Now they have changed the format. It does not happen. But in olden days, this examiner told me the story that when somebody, a resident, smart resident comes in like Eugenio, and he says, either I will tell you 15 cases, or if you tell me the Doppler equation, you are pass. You don't have to see any cases. And he told me in his 20 years of examiner experience, nobody ever took the choice of Doppler equation because everybody was afraid that they will miss something. So the important thing to remember, this is your transducer, this is the blood vessel, and the RBCs are moving. When the sound goes in, the RBC has already moved. So the first Doppler shift has already taken place. Then, as the RBC moves a little bit more, it sends back the echo. That is the second Doppler shift. Because of that, in the equation you have the number 2, because there are 2 Doppler shifts taking place. Now, when the sound goes and hits the blood vessel, then there is an angle. The angle is the angle at which the flow is and then the beam of sound. That is called the theta angle or the cos theta. Now, this is very, very important in Doppler, and you will understand even practically. We will show you why it is very important. The rest is easy. The machine can calculate everything. The machine knows what transducer you used. Let's say it is 10 megahertz. The machine knows what the frequency came back. It can calculate the FD. It knows the angle. It knows speed of sound in tissue, 1540 meters per second. So it can easily calculate velocity. And that is all Doppler is about. Every day we are using Doppler most of the time to find out how fast the blood is flowing. Why is it important to know how fast the blood is flowing? Anybody who has watered plants knows that if you close the hose, the water flows faster. So indirectly, by speed, we know how much is the narrowing. And that is very important, especially in carotid Doppler, peripheral arterial Doppler. If there is narrowing, there is more speed. If there is more speed, it tells you something is wrong. And those are the numbers we remember. There are charts that tell us how much the stenosis is. Now remember, this Doppler signal comes very complex, but the machines are able to extract the signal we need and give us what we want. Essentially, if you think of this as a blood vessel and the RBCs are flowing in it from point B to A, like we talked about the ambulance example, there is a positive Doppler shift happening on this side, there's a negative Doppler shift happening on this side. If the transducer is at a different angle, then what happens is that it will extract that Doppler signal from the blood vessels. Now this part is the Doppler angle. This is also called the angle of incidence. This is very important. Why? Because the accuracy of your velocity depends on the angle. I can look at a ultrasound Doppler image from some other center and tell that this is not accurate, because I can look, the first thing I look is the Doppler angle. Now, if the Doppler angle is 0, that is excellent. We get very good signal because cos 0 is 1. If the Doppler angle is 90, which means you are hitting the blood vessel 90, and we will show you practically today, there is no signal because cos 90 is 0, equation becomes 0, there is no Doppler shift. So it's very important. This is a very simple graph to understand. These are the Doppler angles, 30 degrees, 60 degrees, 90 degrees. As the Doppler angle goes up, these are the velocities. You can see between 0 to 60, there is not much change in the velocity. But after 60, for very small change in angle, the velocity calculation dramatically changes. Because of that, all Doppler must be done less than 60 degrees. The lesser it is, the better it is. It can be 0. It can also be 0 because the blood can be coming towards the transducer. If you are looking at a kidney from the flank and the artery is coming towards the transducer, angle is 0, that's fine, that is still okay. But it cannot be above 60 because then a lot of problems happen. Any cardiologist in the group here today? One basic difference to understand between two types of Dopplers. One is called the continuous wave Doppler, and the cardiologists use that. Okay? They have a transducer which has two elements. One sends signal down, second receives it all the time, continuously. But most of the rest of the world, the non-cardiology world, uses pulse wave Doppler. And the pulse wave Doppler has one frequency transducer which sends the beam, waits, beam comes back. Because of this waiting, it is able to tell from where the signal is coming. This is very important. Because speed is equal to distance and time, by actually putting the Doppler at one value, we can tell how deep it is from where it started. So this brings up one very important concept. Think of it that this is a Doppler wave which went in, then it waits, and then the second one goes. This waiting time is what is called as PRF, pulse repetition frequency. This you will hear again in practical when we do. Very important to have the right PRF, otherwise we will get very bad signals, you know. Now the other important thing is this little gap in the middle of the Doppler, that is called the Doppler sample volume. Every machine has this. Every pulse wave Doppler has this. This tells me at this point, if I put it here, it tells me that the speed of RBCs in this area. It does not tell me what is happening here, does not tell me what is happening here. It only tells me here. It's like a three-dimensional structure through which the blood vessels are going. So this is also called as target area or Doppler sample volume. Now, if you can see here, see how it is very small, and you can see here how it is very big. So you can change the size of the Doppler sample. In arteries, we try to keep it small. In veins, we try to keep it big. That is one basic difference because we want to see how many RBCs are flowing. So that is one simple way to change it. So you can, when you look at these, this is very important. So when you do Doppler, there are three things we have to look at. What is happening to the beam edge? What is happening to the color Doppler? What is happening to spectral Doppler? These are the three terms. Normally, you will make one image, maybe of liver. You will put color. You will find the hepatic artery or portal vein, and then you will put the spectral Doppler on it. But to understand Doppler, we'll understand the spectral Doppler first because that is very important. Every RBC, every red blood cells has one distinct velocity. Okay, it is going at one speed. We don't know what speed, but some speed. Now, if you make a graph and say that this line, horizontal line, is time, okay, that is basically telling the heart is beating, systolic, diastolic. The other line is the velocity. So if the Doppler machine has calculated the velocity of one RBC, just one RBC, and decided to put it on the graph there, then this can be anything, okay, for let's call it 200 centimeters per second. So this is flowing at 200 centimeters per second. Now imagine that is only one RBC. If there are multiple RBCs, they are at different velocities, so it is going to be 200, 250 centimeters per second. The machine is putting a dot. But then there are many more RBCs, and some of them are going at the same speed. What does the machine do? It puts that second dot on the top of the first dot, so the dot becomes brighter. This is a very important concept of Doppler. Now when the RBCs keep going higher and higher and higher, now you have to imagine that there are millions of RBCs in that one little sample which is being done. So all those RBCs are being plotted on a graph with time. The heart is going systolic, diastolic. So you can see in systole blood is going in, diastole it goes down, systole it goes up, and all these RBCs are at different speed. When the diastole starts, the blood slows, and then it goes fast again. So you imagine if you have about 20 RBCs, it'll look like this. If you have 40 RBCs, it looks like this. If you have 1 million RBCs, it is going to look even worse. It's going to look like this. And this is what we see every day. So in the sense, there is no line in the Doppler. It is only a pack of RBCs, multiple dots, very closely, densely packed together, make the waveform. So what we call the spectral waveform is nothing but a pack of RBCs together. That's it. So if you can see, this is the systole, that's the diastole, right? So the heart goes into systole, all the blood vessels go up, all the RBCs are inside, they're packed. The heart goes in diastole, all of them will deaccelerate. They deaccelerate at different rates. That's why you have a little broadening, and then the heart will beat again. That's the fundamental basis of the spectral waveform. This is what we see every day. This is a carotid Doppler. Now, whatever you have seen, there is a Doppler angle, there is a Doppler sample volume, and all the RBCs in this small area are now shown packed together in the spectral waveform. That is how the spectral waveform is created every day. And that spectral waveform gives us a lot of information. Number one, it tells us what is the frequency or Doppler shift, which in other words means velocity. So it tells us what is the speed at which the blood is flowing. Second, it tells us time, because time is there on the horizontal, on the side, on here, this is time. So that is fine. The third very important thing, it tells us amplitude. What is amplitude? It is the whiteness of the spectrum, how many RBCs are flowing. The whiter the spectrum, the more the number of RBCs. That is very important concept because there is something called power Doppler, and that is power Doppler is related to the amplitude. So now we have got the frequency, the amplitude, and the Doppler. One important concept I want to introduce here, and that is a concept of laminar flow and non-laminar flow. So if you're on a big highway and all the cars are going in their own lane, they will all go really fast. But the ones in the periphery will be slower than the ones in the center, always, because of friction, because of being very close to the barriers. Now imagine if there is an obstruction here in the front. All these cars have to go through the obstruction. They all will slow down, and the one in the center will first go very fast through it, and then the others will go. And that is what happens when you have a plaque, a stenosis. All these RBCs will start getting packed. So when I talk of laminar flow, how does that laminar flow look on the spectrum? If you blow up this spectrum alone here, then this little black spot, below the line is called spectral window. If I see that, the diagnosis is laminar flow. Why? Because it means all the RBCs are close together, and then in diastole they are still close together before they go up again. There is no RBC in this velocity zone, so no RBC is very slow in the spectrum. So clean, this is laminar flow. Now what happens if you have a disrupted laminar flow, or the term is called turbulent flow. Now imagine suddenly there is an obstruction, for example here in this carotid, and see what happened to the spectral window. There is no window. And here you can see the window, here no window. This is left internal carotid, this is right internal carotid. Window present, no window. This means that the RBCs in this location are at multiple different velocities. Some are very slow, some are very fast. They are trying to get through that small narrowing. And that is also called as loss of spectral window. So if as a resident you have to talk about turbulent flow, then the word to say is that there is spectral broadening. The spectrum was broad here this much, but here the spectrum has broadened all the way to the baseline. So turbulent flow, very important. See, clean flow, turbulent flow. So once you make the diagnosis, it's fairly easy. The other interesting thing is angle. Now imagine that this is your curved transducer and you have a straight blood vessel. The flow is from left to right. The transducer, when it sees here, it thinks that the blood is coming towards it. And as we had just understood, if the blood is coming towards the transducer, positive Doppler shift above the baseline. So you can see the spectrum here above the baseline going up. The same blood in the same direction, when it reaches here, the transducer is thinking that the RBCs are going away from it. So because of that, the spectrum goes below the baseline because this is negative Doppler shift. This can confuse when you start doing Doppler because the direction is one. It is only going from left to right. But the transducer is looking at it from two different ways. That is why when you do Doppler, very important to understand what is the angle your transducer is making to the blood flow. Same thing with curved vessel. This is a linear transducer, curved vessel. Here the transducer thinks blood is coming towards it, positive Doppler shift. Here it thinks the blood is going away from it, negative Doppler shift. This is not reversal. People will make mistake of calling it reversal. And then this huge example of aliasing. This is an artifact you will see every day and you have to rectify it. What does aliasing mean? Remember we talked about PRF. Now, whenever you look at any structure, for example, in this case, the wheels are moving. And if you keep looking at it, after some time your brain cannot understand if the wheels are moving towards the right or they are moving towards the left, because the brain is not able to process the signal. The same thing happens with Doppler. If the velocity is very high, the signal comes back so fast that the Doppler is unable to know what to do. And when that happens, the Doppler looks like this. This is called aliasing effect. Very easy to rectify. You just change the scale. You change the scale. I'm not going to talk about Nyquist limit, but you change the scale and the Doppler will fit in. So basically, aliasing can be corrected by changing the PRF. It's very important and very important to do that. Now, I want to spend next 5 minutes on the color Doppler because this is very important. What is the difference between spectral and color? Now think that the machine has been designed that it will give some sort of coloration to the flow. Flow towards the transducer will be given one color, flow away from the transducer will be given another color. It does not have to be blood, it can be any flow. So here is an example of a ureteric jet, that is urine coming out into the urinary bladder, coming towards the transducer, red in color, positive Doppler shift. This is a baby, this is the profile of the baby, this is red in color. What do you think is happening? Is the baby drinking the liquor or is it regurgitating? Anyone? You don't know? Yeah, you don't know. Why? Because I have not given you the color scale. Right? This is the color scale. Now you can tell, because if the flow is towards the transducer, it is red. So this baby is regurgitating. Okay? This is vomiting. He is not drinking. Okay? Because this is red. Now I can change that. Now what happened? This has become blue. Now the same image, if I show you and ask you what is happening, now this is going away from the transducer as red, so now he's drinking the liquor, swallowing. So what is the most important lesson? The most important lesson is to look at the scale. The scale tells us what is happening. Whatever the color here is, that is what is happening. Okay, red is not always arteries, blue is not always veins, it is flow direction. So very important to understand that flow direction mechanism. The other important difference in color is this, that when the machine gives a certain color, it only gives a color of average change. So if a blood vessel is showing RBCs, the dark red are slow RBCs, orange is faster, yellow is fastest, but not the fastest because it is the average of all the velocities. The color is given like this. So if I put a little pixel here and say how much is the speed here, it cannot tell you this is 240 centimeters per second. The spectrum can tell 240 centimeters per second. But I can tell you relatively that the RBC of this color is faster than the RBC of this color. So average velocities on color Doppler, that's important to sort of remember. So let's look at one thing. So let's look at this. See how the center is lighter and the periphery is darker. So we know that these are little faster RBCs than the periphery. Now to complicate matters, they introduced something called as beam steering. Okay, this box can be tilted either way you want. It can go this direction or it can go this direction. And based on the direction of the steering box, the color can change. And this is something we'll practically demonstrate to you why it is important. Because if it is red here, if I change the box to this direction, this could become blue because the transducer thinks blood is going away from it. So the steering box is very important to understand in terms of direction of imaging. Here's an example. If you look at it, the blood flow is same, right? This arrow is showing the same. Blood is going from left to right, okay, or right to left, right to left. But look at the steering box. In the same blood vessel, if the steering box is this side, the transducer thinks blood is going away from it, gives it a blue code, so blue. But if the steering box is this side, pointing towards the blood, the transducer understands the blood is coming towards it and gives it a red code. So this steering box is very important to understand. But here the steering box is straight. So the transducer doesn't know, is the blood coming or is it going? So because of that, it has blue and red, because it cannot understand the direction. So that's where you can use the steering box to your advantage. This is again, look at the confusion of the steering box. The steering box doesn't know. It thinks, oh, from here it says, oh, it's coming towards me, and here it's going away from me, so it's giving different colors. So color Doppler basically can change based on the steering box. Now, as far as you look at the color map, as I told you, anything that is lighter here means the RBCs are faster, and these are the slower RBCs. Color also has the angle problem. If the angle is 90 degrees, you may not see any flow, but we can rectify that with the steering box. So that is something we'll practically see. Here again, this is not no flow, this is a technical issue. The carotid is 90 degrees, so because of that, we don't see any flow. Now, one important artifact here in color, and that is to understand color aliasing. This black line has a role, because if the blood goes from dark red to dark blue, that is reversal. But if it goes from dark red to light red or orange, that is faster RBC. So I have correlated this with what you see on the Doppler. Now, if you have a Doppler that is aliasing like this, okay, your blood flow is gone up, wrapped around from down. How does it look on color? On color, the RBCs, faster RBCs will go up to a certain level, and then if the speed is even more than the spectrum, this RBC will come and give a light color on the other side. That tells you there is aliasing happening. So example here. See how the color changed from light yellow to light blue. That tells me that RBCs changed from this side to this side of the spectrum. So this is color aliasing, and again can be easily rectified with PRF. Okay? Important to remember that when it changes from light to light, that is aliasing, but if it changes directly to dark, that means that is reversal. Okay? Reversal is different from aliasing, and I'll give you the example here. On Doppler, very easy to tell reversal. Above the baseline, below the baseline. How do you tell on the color Doppler? Now look at the carotid bifurcation. The blood comes and hits the carotid. It turns here a little bit before it goes forward. If I take a larger view, I can show you that there is a little black spot here. And this black spot correlates with this black band in the middle. So that tells us that there is a reversal here, not aliasing. So in this image, now you understand that this part is aliasing, whereas this part is reversal, because there is a black margin between the red and blue. So very easy to understand on color Doppler what is aliasing and what is not. Here is an example of a carotid. You can see this is aliasing. There is no black line between blue and yellow. And this is a peak systolic velocity, 98 centimeters per second, so we can easily calculate. What happens here, this is a kidney with a lot of perfusion. So what happens here is, why is the blood so much multicolored? Because there are many small vessels which are turning over here, tortuous. So the transducer cannot say whether it's coming towards it or away from it. So all this tortuosity of the vessel is shown because there are multiple Doppler shifts. Okay, I want to end with this power Doppler image. Remember, I told you there are three components to the power Doppler, and one is called intensity or amplitude. If the machine is allowed to only look at that amplitude signal, you don't know the direction. When I look at this image, I don't know if the blood is coming towards me or away from me. But what I know is perfusion is excellent. So power Doppler is used whenever you have any structure which has slow flow, or you want to know if there is perfusion. So that is other thing we can show. And I know Mindray machine has got some new flow technologies in their equipment, which we can also see in the practical demonstration. So basically, any Doppler provides three types of information. What is the speed of a structure? What is the intensity? And then turbulence. What does turbulence tell us? Is there stenosis or there is no stenosis? So this, I think, was a brief review of the principles of Doppler. In every lecture you will hear today by the entire faculty, some components of this will be there, whether it is a part of Doppler sample volume or filter or stenosis, turbulence, aliasing. You will hear these words again and again. Thank you very much. Oh. People are not getting a coffee break? Oh my God. Okay, the next 20-30 minutes we'll spend on the carotid ultrasound. So we'll look at some background of it, we'll look at some technique, we'll look at plaque characterization, how to grade stenosis, and some pitfalls. So why do you want to grade stenosis? It's very important because when there is turbulent flow, and we just learned about turbulent flow, that turbulence will cause plaque instability, right? So we have a plaque in the carotid made of cholesterol and all the nice Chilean sweets and Indian sweets, they all go in the carotid and become a plaque. Then there's turbulent flow, it will cause embolus, and the embolus will go to the brain, you'll get a stroke. So because of that, we want to know how much is the stenosis. Now, there are multiple trials which have already taken place, but all agree on one thing. There is clear benefit from carotid endarterectomy for patients with stenosis in 70% or more. So there are two reasons we do carotid Doppler. Number one, is there a stenosis more than 50%? Number two, is there a stenosis more than 70%? If there is a stenosis more than 70%, surgical treatment. If the stenosis is between 50 and 70%, medical treatment. So very important to find the right number to define when medical versus surgical treatment is done. There are two things you will do, and when I show carotid Doppler, there are two things. One is grayscale. We just look at grayscale and we look at a plaque and we say, hey, is this plaque soft, hard, ulcerated? Can it cause emboli? That is one part. The second part is the plaque causing stenosis? And if there is stenosis, how much is the stenosis? So these are the two answers we have to give. Now this is very important to understand. When somebody sends you a carotid Doppler, whether you're a radiologist, sonographer, non-radiologist, you are only looking at a very small part of the carotid, especially the internal carotid artery. When we, in our language, say proximal, mid, distal ICA, we are only talking of maybe 2 to 2.5 centimeters of the internal carotid artery from the bifurcation. This is important because what happens is sometimes our colleagues, if I say the distal ICA is normal and they find some plaque or narrowing or dissection in the MR angiogram very close to the skull, they think that we missed it. But when we say distal, we do not mean the distal ICA by anatomy. We mean the distal ICA by the component we have assessed. And we only assess 2 to 2.5 centimeters of the internal carotid artery from the bifurcation. We almost can't go further up because the vessel makes a tortuous turn and is very difficult to see. So this education is very important with our clinicians so that they understand that in anatomy, even the distal ICA is technically the proximal component. Important for them to understand that. Now, when we look at a plaque, there are a few things we want to say. Hey, what is the quantity of the plaque? What is the echogenicity? Darker hypoechoic plaques are dangerous. Whiter calcified plaques are less dangerous to emboli. We can look at the waveform and see what is happening. We will look at the stenosis. We will compare the speed of sound in ICA versus the CCA. That gives us a ratio. If the speed goes more than twice, that is more than 50% stenosis. If the speed goes more than 4 times, that is more than 70% stenosis. So we have these criteria. How will you describe the plaque? So you can use words like there's a focal plaque, scattered plaque, diffuse, and then quantify it. Is there minimal, moderate, or a bulky plaque? Surface, very important to comment on surface. Smooth plaque, less likely to embolize. Irregular plaque, more likely to embolize. Echogenicity, As I told you, hyperechoic, more stable plaques, hypoechoic, less stable plaques. So when you look at a blood vessel, the machine's resolutions are really, really good. Look at the intima media here. The intima media is very well seen. The lumen is anechoic, nicely filling up. This is a very clean intima. But the normal patient does not come like this. The normal case will be something like this. So here, if you see, I have stitched 3 images to show a longer length of the vessel. So this is the common carotid proximally, common carotid distal. This is the bulb. This is the proximal ICA. This is the cross section of the ICA. These images are giving us a lot of information. How are we going to tell the physician what is happening? So one part can be, we will say that there is a moderate focal plaque at the carotid bulb. So this is the bulb, and there is a focal plaque here along the wall. Very well seen. So we've already told the quantity and the location. What else can we put in our report? Okay, what kind is it? So it is a smooth plaque. It looks fairly smooth here, which makes it stable, less likely to embolize. So we'll say, okay, there is a smooth plaque. So we've commented on the surface. And the last thing is, we want to know what is the echogenicity of the plaque. So now we say it is hypoechoic here, but it is echogenic in these parts, which are calcified. So we have to say, well, there is a smooth hypoechoic plaque at the carotid bulb, which is this guy, and then there are mild or small scattered echogenic plaque in the ICA and distal CCA, which are these and these. Just by looking at it, we know 2 things. The hypoechoic plaque is the dangerous one. This is the guy which can become bigger, which may embolize. But one thing good for this plaque is it is still smooth. If this becomes irregular or ulcerated, then this becomes a dangerous plaque. Nevertheless, all this information must be there in the carotid report. Why is this important? Because this cross-section view tells you how much is the lumen which is narrowed. Remember, we have not yet measured the velocities. We are just visually looking at it. Okay? And in the cross-section, I can almost say that 1/3 of the lumen is gone. Now I need to find by a peak systolic velocity how much is the narrowing causing hemodynamic change. So that is a separate component of the carotid evaluation. So hypoechoic plaques can be very subtle. You will miss them. That's why color Doppler helps. So on the same area, I had only seen this plaque, but I had not seen the hypoechoic plaque here. When I put the color Doppler, this part of the vessel is not filling up. So this is a second plaque. This is a little bit more dangerous plaque. Why? This is in the proximal ICA versus this one which was in the bulb. This one does not have a margin that is very well defined. So color Doppler helps to sometimes understand where the margins are. Here's another hypoechoic plaque, a little bit more irregular, but to know the true extent, good to put the Doppler. And you realize that even though initially we thought the plaque may be finishing here, it is more confirmatory that the plaque is extending further out. So this is a much longer plaque than we initially thought. So these are the little nuances which are important. Now, when you have calcification, things become very difficult. Sometimes you can get what we call pseudo-ulceration. So here, I thought there is a calcified plaque, and then the color Doppler filled in this little crater, but this is just an overbleed of the color and not a true ulcer. Sometimes you have calcification which doesn't allow you to visualize the lumen. And in this case, very important to say we did not see. Why? Because this patient will go to a CT angiogram and they might find the lumen which we all missed or could not see. So when we cannot see because of calcification, after we have tried a different approach, we again send it for further evaluation. What is one different approach you can do? You can do a cross-section. So when I did the cross-section, I realized there is a calcified plaque here, and there is another plaque here, but this wall does not have any plaque. So maybe to evaluate this, my transducer needs to move from this direction to this direction to find the flow. So sometimes those minor modifications can be done. Here's another example. So this is the proximal ICA. So intima media thickening, and then we hit a plaque. And see, this calcified plaque is almost 1 centimeter, big black shadow behind it. We don't know what's happening in the lumen. Very important to say, we did not evaluate the lumen in such a case, and this definitely needs to go a CT angiogram if the patient is symptomatic to find out what's going on. Here's another good example of a plaque with a proper ulceration. Now, if you look at this, this is a hypoechoic line going here, then there is a crater, and then a little ledge, and the color is filling up that spot. What might have happened here? Sometimes, if this is a soft plaque, it could have broken, and this part has gone as an embolus, and patient comes to you with a stroke or TIA. So it's important to again use these characterizations. One more pitfall. If you put color Doppler, especially with calcified plaques, you can get this twinkle artifact because the calcium will sort of vibrate and cause this little echogenicity. You initially think that this is an ulceration here, but actually when you decrease the color and optimize it, you realize that this band is not only there, it is going all through. That's because of the twinkle artifact of the Doppler. Many pitfalls when we are looking at plaques, as we have seen. So be careful looking at hypoechoic plaques. Use color Doppler to define the margins. Do not overcall ulcers, and do not get confused by the twinkle artifact. So now, from the plaque characterization, the second part is what is the velocity in the artery? How fast is the blood going? And that is all pulse Doppler. We have to know from the spectral Doppler what is happening. Same process of definition of the vessels, and we might do some additional sampling sites apart from looking at the common carotid artery and the ICA, the ECA, and the vertebral artery. Now, I had told you the angle should be less than 60 degrees if you want accurate velocities. But if you can get angle even less than 50 degrees, your accuracy goes higher. So we actually tell our sonographers to try to keep to 50 or less, but between 50 and 60 is still okay. So here's a normal ICA, beautiful center Doppler sample volume, very nice tight spectrum, good spectral window. The small dicrotic notch which happens here in the waveform is cardiac related and nothing to worry about. So that is the ICA. Now, what happens in the bulb is a little bit important to remember. The bulb is patulous area of the carotid, and the velocity you get may not be super accurate. That is why for all the criteria of stenosis, we are only looking at ICA velocities and we do not worry about the bulb. When we calculate the ratio, we do not do the ratio between the bulb and the ICA, we do the ratio from the mid common carotid artery and the ICA. That's how you calculate it. Now, the ECA is a blood vessel that has got multiple muscular branches because it is supplying the muscles of the face. Because of that, it has what we call as a high resistance flow with the dicrotic notch coming deeper. You can see this dicrotic notch comes all the way down to the baseline, and low diastolic flow compared to the ICA. So these are the waveform differences between ICA and ECA. Very important to differentiate these in the carotid Doppler, okay, because ECA will always have faster velocities than the ICA, and you don't want to call the ECA as the ICA. And there is one trick you can do to confirm that you are in the ECA. One, the ECA has branches in the neck, the ICA has no branches. Number two, when you do temporal tapping, that means this preauricular artery, there is an artery here in front of the ear. If you press on it, because it's a muscular artery coming from the ECA, you will see the waveform change in the ECA, but not in the ICA. How does that show? So look at this vessel here. What happened here? This is where the temporal tapping took place. You will not see this if you were in the internal carotid artery. The second thing is a branch. You can see a little branch take off from here. So once you see a branch, you know that this is the ECA, this is probably the ICA. Again, another example, confusion, is this ECA, ICA, which one is it? So we do the temporal tapping, and you can see this multiple sawtooth appearance. that confirms that this is the ECA. So very simple. When we do the exam, you can see and you can do it yourself. So grading stenosis becomes a very critical issue, right? How will we accurately say that there is 50% stenosis or there is 70% stenosis? Now, historically, people have come up with some numbers, right? PSV is peak systolic velocity, EDV is end diastolic velocity, and ICA by CCA ratio is the ratio between the speed of RBCs and ICA versus the CCA. So if I show you this graph here, where is the peak systolic velocity? In this waveform, this top part is the peak systolic velocity. Where is the end diastolic velocity? When the waveform goes down, 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 before it goes back up, that last point is the end diastolic velocity. In the middle, nothing matters, okay? So traditionally, the criteria the world has followed for almost 15 years, and it has changed, that's why I'm stressing this a little bit now, is the SRU criteria. The SRU is the Society of Radiologists of Ultrasound. Ed Grant published this article in 2003. We are in 2022. So this criteria has sustained itself for 20 years. But we made a minor change now. What the criteria said, and every resident used to mug up these two numbers, was that if the peak systolic velocity was above 125, it was more than 50% stenosis. And if the peak systolic velocity was above 230 centimeters per second, it was more than 70% stenosis. Every resident mugged up that number all the time. But we started realizing that at 125, it seems very low. And some patients were being treated with statins or getting a stent just because the number was slightly higher. And somebody said it was more than 50% stenosis. So we looked at it a little bit more carefully. And in Mayo Clinic, we did a minor modification. The modification we did was we decided that if you have to do a good carotid estimation, you need to have a chart. The chart should look at four things. What is the peak systolic velocity of the ICA? What is your visual estimation of the plaque? What is the ICA to CCA ratio? And what is the ICA's end diastolic velocity? Because as the vessel gets narrowed, even the end diastolic velocity will go up. And we became a little bit more generous and decided that the moderate stenosis becomes a little bit more relevant at 150 centimeters per second rather than 125 centimeters per second. But this method by which we started making this calculation was more based on experience. So then the IAC stepped in. The IAC is the Inter-Society Accreditation Commission. It is made up of multiple societies. And in 2014, they issued a white paper saying that there is a variation in the criteria used to interpret ICA stenosis, and they wanted to look at it again. So we did this very big multi-center study in which we looked at all the blood vessels again. So we correlated with conventional angiograms, and we published this paper in 2021. So last year, we published this paper, and this was a report from the ICA. As you can see, I myself was a part of this group, and this group extended the vascular surgeons, vascular medicine, cardiologists, radiologists, all across the United States. And Lawrence Needleman from Jefferson, he was there in the first criteria also. And we realized that the higher peak systolic threshold value of 180 centimeters per second was more reliable to diagnose 50% stenosis. That number is much higher than the 125 we have historically used. So with that, we published this new criteria. This is part of the paper. You can always go back and look at the paper. This is the same SRU criteria with one change, and that change was that 50% stenosis should be called after you cross 180 centimeters per second. There was one big thing we also did. We realized that depending on one number, any number you choose in science is a balance between sensitivity and specificity, right? So at 180, your specificity is high, but your sensitivity may be low. You may miss something because your number has gone high. How do you balance that? So we decided that the ratio also is very important. So if what we decided was we changed, this is our Mayo Clinic's current guideline. We changed one thing in our paper, and that was that, okay, if it is 180 centimeters per second, we will go towards moderate stenosis more than 50%. But if it is 150 centimeters per second, we will also look at the ratio. So we added here. If the peak systolic velocity is less than 180 centimeters per second, but visually you think moderate plaque is there, and the ICA ratio is more than 2.0. So if your number is less than 180, but the ratio is more than 2.0, it still becomes 50% stenosis. So the ratio and the absolute number became very important in the new criteria. And I think this has become now being used in multiple places and for accreditation of vascular labs. So with that, let's look at this one case. And I've given you some images. There is a bifurcation of the carotid, beautiful heterogeneous plaque, multiple calcifications. So the tech has put the transducer here, and this is for you to see. So common carotid artery 53, ICA 168, end diastolic velocity 55, a ratio of 3.2. Where do you think the stenosis is? Moderate, severe? You need a calculator. Phone a friend. What do you think? Moderate. Why? Because seems like it was all falling in our criteria, and the ratio was 3.2. So even though our new number is 180 degrees, and this might have been less than that, the ratio was more than 2, so we still kept it in the moderate range. All right, second case, carotid 47, ICA 261, ICA end diastolic velocity 109, ratio 5.6. Severe, right? This is classic severe because now you have gone to 261, that is above the old number, 230. 230 is even today the right number for 70%. If there is one number you want to remember, remember 230 centimeters per second, because that differentiates medical versus surgical treatment. So this is severe still because the ratio is extremely high. Case 3, 67 for CCA, 225. A little tricky because 230 is the number and I gave you 225, and the ratio is 3.4. Moderate, kind of just falls right in the moderate, almost coming in that extreme, but sort of borderline, but still within the zone there. Case 4, 93, 226, 30, ratio 2.4, still 2.4, still falling in that moderate. So this is the chart we use. It is printed and kept in our, this chart is in our reading room, and we just look at it and quickly circle and decide mild, moderate, severe, and give the report out. I'm going to go to a different case. This was this case, which was very little bit confusing. So here, the common carotid is 106. The ICA is 288, but the end diastolic velocity is very low, 20, and the ratio is 2.7. So ratio is less than 4, so I'm thinking moderate, but the ICA is 288, so I'm thinking of severe. So there is a discrepancy in what is happening here. One is going in the marked zone, and one is going in the moderate zone. So I have to, and then the end diastolic velocity is going in the mild zone. So we have 3 different numbers in 3 different sections. Where will we go? So you go back to the image, and now you look at it grayscale, visually. And visually, that does not seem to be a very big plaque. So because there does not seem to be visually a large plaque, we will disregard this number a little bit and still go with moderate stenosis, that this is somewhere around this, because visually the plaque is moderate. So many times these sort of things have to be done. Now, some cases difference. Patient has already had endarterectomy. If patient has already had endarterectomy, numbers will not be the same as your criteria. In fact, the vessel has a scar tissue or fibrosis, so it is stiffer. And if it is stiffer, some numbers will already be high. So when you have patients who have had surgical intervention, then disregard the number and do not jump only on the number, give it some more laxity. These 3 Doppler waveforms I want you to visually remember. Why? Because this part is called thumped flow, right? Blip, nothing, blip, nothing, blip. So whenever you see this, the stenosis is afterwards, okay, or distal, right? This is classic Tardus parvus flow, or what they call slow to rise and slow to fall, okay? Low resistance flow, always after the stenosis, post-stenotic. And this is high turbulent peak systolic velocity. This is in the stenosis. So if you have a pipe, this is pre-stenotic, intrastenotic, post-stenotic. That tells us a lot of things sometimes when the velocities are not helpful. So for example, this is this ICA, Tardus parvus flow, CCA, Tardus parvus flow. Velocities, useless. They don't help us anything, right? 46, 46, very low velocity, ratio perfect. By numbers, everything is perfect. By waveform, everything is imperfect, right? So if we have Tardus parvus in ICA, Tardus parvus in CCA, where is the stenosis? Proximal, right? Because this is distal. Whenever you see Tardus parvus, it is distal to the stenosis. So where is the stenosis? We don't know. So we are going to look for this change from this waveform. This became this. That's a post-stenotic waveform. So in this patient, it was at the origin of the common carotid artery, calcified plaque there. Because it is stenosed here, this was Tardus parvus, Tardus parvus, Tardus parvus. Everywhere else, low velocities. The absolute number had no meaning, okay? But the waveform told us something was wrong, right? And this is the other one. I told you about thumped flow, like this knocking flow, blip, 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 blip. Whenever I see this, I know something is wrong distally. So ICA proximally is like this. There has to be a distal high-grade stenosis or obstruction in the ICA. I can't see it, do an MR angiogram. Last couple of slides about the vertebral artery. The vertebral artery hides behind the transverse process of the vertebrae, and we'll show you how. So you can see, you will see it interrupted like this. This is the transverse process, shadowing, transverse process, shadowing. Vertebral artery and vein, artery and vein. This is a normal waveform. There is only one thing you need to recognize. You will pick up stenosis, but the most important thing is to pick up subclavian stele. See how the waveform has changed. Some of it is coming in front, some of it is coming in back. Some of it is coming in front, some of it is coming in back. Whenever you have this sort of waveform change, they also call it a bunny ears, like a profile view of a bunny sitting there with ears. But whenever you see this, this means that there is a stenosis somewhere in the subclavian artery, and blood has found a way to bypass it. So this is a repeat of some anatomy for you. But if you imagine that this is the innominate artery, gives the right common carotid artery and subclavian, and the right vertebral artery. The right vertebral artery goes up, unites with the left vertebral artery, which comes down. So from the arch of the aorta, you have innominate artery, left common carotid artery, left subclavian artery. If the subclavian artery is obstructed, this vertebral artery reverses, gets blood from the opposite side, and it comes down into subclavian. So that is what is happening. That is why we are seeing this reversal, partial stele, subclavian stele syndrome. So this is very important to diagnose. All right, we'll finish this with one case, and we'll see how you understood what is happening. No velocities to remember, just look at the waveform, okay? And there is no two sides to worry, it's only one side. So look at one side, right common carotid artery, tarsus parvus flow. Right internal carotid artery, tarsus parvus flow. Right vertebral artery, tarsus parvus flow. So where is the stenosis? Brachiocephalic trunk or innominate, because it has to be stenosed proximally. So everything else has become post-stenotic, including the vertebral. So of the choices, you had the innominate as D, and that's exactly where it was. If you notice, the innominate is this artery. The innominate comes from the arch of aorta, becomes a subclavian, the common carotid, vertebral. If there is tarsus parvus here, then something is wrong here. So we do the CT angiogram, and high-grade stenosis at that innominate, big calcified chunk almost obliterating the lumen. Perfect. So you guys have understood the hemodynamics. Thank you very much.
Muchas gracias, doctor Dajilla, por sus excelentes clases. Vi muchas caras sorprendidas con los nuevos criterios de velocidad para el diagnóstico de estenosis carotidia, así que nos llama una primera gran perla en este curso con el aporte del doctor Dajilla. Y ahora voy a dejar con ustedes a la doctora Carola Carvajal. Ella es radióloga especialista en ultrasonido de la Clínica Santa María. Tiene mucha experiencia en esta área, muchas horas de transductor. Así que le damos la bienvenida y ella nos va a hablar sobre patología arterial periférica y su evaluación con ultrasonido Doppler.
Buenos días, muchas gracias por la invitación. Vamos a hablar entonces del Doppler arterial periférico. Tampoco tengo conflictos de interés. Y vamos a partir un poco también hablando de la anatomía del sistema arterial periférico, donde vamos a evaluar en este estudio desde la arteria femoral común hasta la arteria pedia. Y acá tengo un poco las velocidades, no para que uno se las aprenda, pero sí para tener una idea de que las velocidades, a medida que vamos a ir descendiendo en la extremidad, van a ir también las velocidades disminuyendo. ¿Cuáles van a ser las indicaciones del estudio? A nivel general, la enfermedad arterial oclusiva, traumatismos, masas pulsátiles, seguimiento de procedimientos endovasculares, evaluaciones postoperatorias. Como a nivel de grupo de indicación de estudios, tenemos la isquemia crónica o la isquemia aguda, con el objetivo principal de localizar y determinar la severidad de la enfermedad arterial. La enfermedad arterial oclusiva es la principal patología que va a producir todas las alteraciones antes mencionadas, y se produce secundaria a la arteriosclerosis. La prevalencia sabemos que va a aumentar con la edad, donde solo un 10 a 20% de los pacientes van a ser sintomáticos. Lo importante aquí es que la consecuencia de esto va a ser la amputación de la extremidad del paciente. Por lo tanto, nuestro principal objetivo y en qué tenemos que enfocarnos es en determinar si existe obstrucción o estenosis de arterias principales de la extremidad que vamos a evaluar. Consideraciones previas a hacer el estudio, como mencionó el doctor Neri previamente. Las velocidades de flujo en este estudio no van a determinar el tipo de tratamiento, como las carótidas, en el fondo, que la velocidad de flujo determina el tipo de tratamiento. Necesitamos un ángulo adecuado, como vimos, entre 30 y 60 grados. Y es muy importante que las velocidades deben ser confiables para poder determinar el grado de estenosis. Y aquí tenemos que recordar el principio de Bernoulli, donde el aumento de la velocidad va a ser inversamente proporcional al área de estenosis. Y tenemos que tener siempre en cuenta que las velocidades en las estenosis va a ser mayor que en los segmentos proximales. Como bien dijo el doctor Nervi, vamos a evaluar los vasos arteriales en el modo B, en el Doppler color y en el Doppler espectral. ¿Qué esperamos ver en el estudio en modo B? Lo normal es ver un vaso con paredes lisas y lumen hipocogénico, como tenemos ahí en la foto. Y lo patológico, o que esperamos encontrar, pueden ser áreas de ateromas con o sin calcificaciones, calcificación propiamente tal de las paredes arteriales, trombos intraluminales, dilataciones anormales o aneurisma arterial. Entonces, aquí tenemos una placa ecogénica que genera sombra acústica posterior. En este otro caso tenemos múltiples placas que van a comprometer las paredes arteriales. Y aquí tenemos una placa que compromete el lumen arterial. Después tenemos el compromiso intraluminal con material ecogénico, que va a ser el trombo intraluminal. Y las dilataciones, que vamos a tener que siempre comparar la distancia anteroposterior del vaso distal y en el aneurisma o en la dilatación, teniendo en cuenta de que vamos a hablar de un aneurisma popliteo cuando el diámetro de la arteria sea mayor a 10 milímetros y en la arteria femoral común mayor a 15 milímetros. Después nos vamos a ir al estudio con Doppler color, donde lo normal, como veíamos en la clase previa, es tener un patrón de flujo pulsátil con alternancia entre el rojo y azul, dado el flujo reverso en la fase diastólica. ¿Y qué alteraciones vamos a tener al Doppler color? Podemos tener estenosis, donde vamos a tener un área de turbulencia del color o aliasing. Y es muy importante aquí que distal a la estenosis tenemos que disminuir el PRF porque la velocidad del flujo va a disminuir. Podemos ver oclusiones, donde va a haber claramente una ausencia de flujo. Y es importante tener en cuenta que en el Doppler color podemos a veces no tener visualización de flujo cuando hay calcificaciones de las paredes arteriales que nos van a impedir ver el flujo. No es que no exista, sino es que no lo estamos viendo porque las calcificaciones de la pared lo están impidiendo. Entonces aquí, en el mismo caso, como veíamos anteriormente, esta placa, tenemos un flujo que es prácticamente normal. Y en este caso tenemos una alteración del flujo, una turbulencia, un aliasing, que más detalladamente nos va a mostrar una disminución del calibre, una estenosis. Y esta alteración del color que nosotros vemos, tenemos que ir obligadamente a estudiarla con el modo Doppler para ver qué está pasando ahí con las velocidades. En este otro caso tenemos una calcificación de la pared que nos va a impedir ver el flujo en este segmento. Y en estos dos casos las calcificaciones de las paredes son tan abundantes que vemos únicamente segmentos del calibre, digamos, del vaso, y podemos ahí ir a ponerle el Doppler y vamos a ver que hay una curva de flujo normal, digamos, a diferencia de este último caso donde el color no nos muestra flujo porque las calcificaciones, o sea, porque el lumen está obstruido y hay una oclusión. A nivel del Doppler espectral, en el 2020 se hizo un consenso donde se determinó que la interpretación de las curvas tenía distintas nomenclaturas. Entonces, para unificar las nomenclaturas de las distintas curvas, se hizo un consenso. Yo voy a hablar acá únicamente de lo que nos atañe aquí, las curvas arteriales. ¿Y en qué quedó esto? Es que las curvas arteriales tienen características principales que van a estar determinadas por la dirección del flujo, la fasicidad, la resistencia, y se agregan otros términos como los trazos, los ensanchamientos espectrales y cosas que vamos a ver más adelante. Entonces, respecto a la dirección del flujo, vamos a tener ahora flujos que son anterógrados, que van a estar sobre la línea de base, pudiendo tener a veces en el fondo algunos segmentos bajo la línea de base. Flujos que se le van a llamar ahora retrógrado, que en el fondo previamente conocíamos como el flujo reverso, ahora tiene el nombre de retrógrado. Los flujos bidireccionales, conocidos como el to and fro, que tenemos curvas sobre y bajo la línea de base, y el flujo que es en el fondo el flujo ausente, donde no tenemos flujo. Respecto a la fasicidad de las curvas, ahora hablamos únicamente de curvas multifásicas o monofásicas, incluyendo dentro de la curva multifásica las que son trifásicas y las bifásicas. Acá no hay una diferenciación entre tri o bifásico, se habla solo de multifase. Después, la última característica principal es la resistencia al flujo, que las curvas nos van a mostrar curvas de alta resistencia que se van a caracterizar por ascensos rápidos y descensos rápidos, que pueden o no tener un componente diastólico y un flujo retrógrado. Una resistencia intermedia que va a estar caracterizada por esta muesca de fin de diástole con un flujo diastólico posterior, y una baja resistencia que tiene únicamente flujo sobre la línea de base, con ascensos y descensos que son lentos respecto a las curvas de alta resistencia. Otras características van a ser el ensanchamiento espectral, que hablan del, según lo que explicaba este consenso, el ensanchamiento espectral podemos verlo en flujos laminares y no laminares, no solamente en flujos turbulentos. Tenemos la curva tipo estacato, que en el fondo son curvas, como decía el doctor, previo a estenosis u oclusiones, y el flujo atenuado o conocido el tardus parvus. Entonces, veíamos que la patología principal que nos interesa descartar cuando hacemos estos estudios es la estenosis arterial. ¿Y qué es lo que vamos a ver ahí? A nivel del Doppler color, vamos a ver un flujo que es turbulento. En relación al Doppler espectral, tenemos que evaluar proximal a la estenosis en la estenosis distal. Lo vamos a ver con más detalle en las próximas diapositivas. Y lo importante aquí es tener en cuenta que el principal criterio para determinar la estenosis va a ser la velocidad pic sistólico, va a ser este índice entre la velocidad en la estenosis y proximal a ella. Entonces, ¿qué podemos encontrar en la estenosis misma? Va a depender de cuál sea el grado de obstrucción del lumen. Con obstrucciones menores al 50%, es decir, unas obstrucciones que no van a ser hemodinámicamente significativas, vamos a tener curvas que son multifásicas y de alta resistencia, pero con velocidades que van a ser 2 veces mayores a lo que son previos a la estenosis. Con obstrucciones entre un 50 a un 74%, podemos tener también curvas multifásicas o monofásicas de alta resistencia, y aquí la velocidad entre la estenosis y el lumen proximal a ello va a ser mayor a 4 veces, entre 2 y 4 veces, perdón. Y cuando ya la obstrucción es significativa, es decir, entre un 75 y un 99%, vamos a tener curvas que son monofásicas, de alta resistencia con el ensanchamiento espectral, y la diferencia en las velocidades va a ser mayor a 4 veces. Ahí un poco lo que hablaba también el doctor en sus clases previas es la diferencia, este índice entre la velocidad en la estenosis y previo a la estenosis, que menor a 2 va a ser una estenosis menor a un 50%, entre un 50 y un 74%, el aumento de la velocidad va a ser entre 2 o más veces la velocidad previa, y ya más del 75% es más de 4 veces. Previamente se habían descrito las estenosis de acuerdo a velocidades, pero la verdad que este índice de velocidad es más fidedigno que las velocidades mismas. Acá tenemos un caso, no sé si alcanza a ver ahí bien las velocidades, donde primero tenemos, digamos, esta alteración, esta turbulencia, este aliasing de color. Vamos entonces a ir a analizar el segmento previo a la alteración del color, donde tenemos una curva que es multifásica de alta resistencia con una velocidad de 113. Vamos a ir a ver el Doppler en esta alteración del color, este aliasing, donde nos da una velocidad aumentada de 152, y si se fijan la curva aquí también cambió a una curva de mayor resistencia. Y la diferencia de velocidad no es más de 2 veces, por lo tanto es una estenosis que no es hemodinámicamente significativa, y posterior a la estenosis tenemos una curva que es también multifásica con una velocidad que ha disminuido respecto a la estenosis misma. Este es otro caso donde la estenosis es mayor, entre un 50 y un 70%. ¿Por qué? Este caso era un paciente que tenía un bypass femorofemoral derecho-izquierdo, donde tenemos aquí que el bypass de llegada tiene una velocidad de 114. Tenemos aquí en el origen, digamos, de la arteria femoral izquierda un área de alteración, turbulencia del color, que vamos a ir a explorar con el Doppler espectral, y vemos que la velocidad aumenta de 114 a 330, es decir, más de 2 veces menos de 4 veces, y tenemos un cambio aquí en el tipo de curva, donde aquí tenemos una curva ya que es monofásica, de alta resistencia y con ensanchamiento espectral. Y en este caso tenemos una estenosis crítica, donde el cambio de velocidad proximal y en la estenosis misma varía ya claramente más de 4 veces. Tenemos una curva aquí también de muy alta resistencia con ensanchamiento espectral, que nos habla de una estenosis crítica. Como mostraba el doctor previamente, lo que esperamos encontrar distal a unas estenosis significativas son estas curvas monofásicas y de baja resistencia. Ahora, ¿qué vamos a buscar o qué podemos encontrar? Previo a una obstrucción, donde hay un flujo claramente, o sea, detenido, porque en el fondo no hay paso de flujo, son estas curvas de alta resistencia, y distal a la obstrucción podemos encontrar estas curvas monofásicas o de baja resistencia, curvas dampeadas, digamos, o Parvus-Tardus, que serían dadas por presencia de colaterales que están irrigando el segmento distal a esta obstrucción. Entonces, esto nos va a hablar también de que esta obstrucción que nosotros encontramos acá es de larga data, es crónica, porque hay colaterales que nos están irrigando distal a ello. En este caso tenemos sospecha de oclusión porque tenemos flujo que podemos ver, pero claramente la curva nos está mostrando un flujo casi inexistente. Y acá claramente no vemos ningún tipo de flujo, por lo tanto podemos hablar que hay una oclusión de este vaso. Y en este caso tenemos también aquí el origen de la arteria tibial anterior, donde tenemos una curva relativamente normal con velocidades que están dentro de lo esperable. Pero ¿qué está pasando en el segmento del tercio medio? No encontramos flujo al Doppler color, es decir, hay una oclusión, pero en el segmento distal tenemos presencia de flujo con un color que es distinto al del segmento proximal, es decir, este flujo está yendo de manera reversa, y pues ya que se está irrigando por colaterales que vienen distal y van hacia proximal. En este caso tenemos una estenosis que es proximal, entonces, ¿cómo vamos a sospecharla o cómo podemos decir que hay una estenosis proximal? Primero vamos a ir a comparar. Tenemos una extremidad derecha donde la arteria femoral común y femoral superficial muestran curvas de morfología y velocidades absolutamente normales. Si nosotros nos guiásemos únicamente por el color del lado izquierdo, tenemos vasos que son con colores rojos, digamos, con un flujo que está normal. Pero si nos vamos a evaluar la curva, el Doppler espectral, vemos curvas que son monofásicas, con velocidades disminuidas, y a lo largo de la extremidad hacia distal van cada vez siendo curvas más monofásicas, es decir, más post-obstructivas. Y en este caso, la estenosis se encontraba en la arteria ilíaca del lado izquierdo. Este es otro caso, lo mismo, tenemos un lado derecho que son curvas y Doppler color completamente normal, y en el lado izquierdo tenemos curvas completamente monofásicas que nos hablan de una estenosis proximal. Algo que se me olvidó comentar, pero que lo puedo decir a raíz de esto, es que si tenemos una estenosis proximal y vemos estas curvas y distal a ello tuviésemos un área de estenosis, esa estenosis no puede ser adecuadamente determinada porque la velocidad previa, digamos, está limitada por una obstrucción previa. ¿Ya? Entonces, en las obstrucciones que se llama en tándem o que tenemos muchas obstrucciones seguidas, las obstrucciones más distales no vamos a poder determinar el grado de estenosis de acuerdo a la velocidad, porque la velocidad que viene proximal ya está disminuida. ¿Ya? En este caso, podemos ver que la arteria tibial posterior tiene un segmento proximal que está de color normal, tenemos un segmento distal que tiene una alteración de color, que al ir a evaluarlo me da una velocidad que es claramente más de 2 y menos de 4 veces. Y distal a esto me importaba mostrarles acá no solo la alteración de color que va asociado a un cambio en la curva y en la velocidad, pero sino también la curva posterior a esta estenosis, que también cambia respecto a la curva previo a la estenosis. Es decir, esto me habla de una curva post-obstructiva, digamos, post-estenótica, perdón, no obstructiva. Y en este otro caso tenemos una arteria tibial anterior proximal también, que tiene una curva relativamente normal. En su segmento distal tiene una curva normal, pero ya más hacia más distal tenemos flujo retrógrado, porque esta estenosis fue revertida, digamos, por colaterales de desarrollo crónico. Y ya más a nivel incluso más distal, no se ve ahí porque se perdió, pero esta es la arteria pedia, donde si bien tenemos flujo que es de dirección adecuada, digamos va desde proximal a distal, es post-obstructivo y tenemos curvas que son completamente monofásicas. A modo de conclusión, entonces, el objetivo del estudio digamos, del Doppler arterial de extremidades inferiores va a ser localizar y determinar la severidad de la enfermedad arterial y determinar si existe obstrucción o estenosis de las arterias principales de la extremidad, teniendo en cuenta de que los pacientes que tienen esto pueden llegar a la amputación. Tener en cuenta siempre el principio de Bernoulli, donde un aumento de la velocidad va a ser siempre inversamente proporcional al área de estenosis y por lo tanto la velocidad de las estenosis siempre va a ser mayor a las de los segmentos proximales. El criterio para determinar la estenosis es la velocidad de picos sistólicos, este índice que yo les mencioné de la velocidad en la estenosis respecto a la proximal. Y a nivel de curvas, podemos en el fondo recordar que tenemos un flujo normal con curvas que son de alta resistencia, curvas multifásicas. En flujos preestenóticos podemos tener estas curvas en el fondo monofásicas. A nivel intraestenótico siempre vamos a tener curvas de alta resistencia con el ensanchamiento espectral y a nivel postestenótico estas curvas de baja resistencia monofásica. Como les decía, las placas en tándem no permiten determinar estenosis distal adecuadamente porque la velocidad proximal no viene, digamos, dentro de lo normal para el vaso. Y las estenosis proximales van a producir asimetría de las curvas en las extremidades inferiores. Y eso sería...
Doctora Carvajal, ahora vamos a ir al coffee break. Antes de eso voy a leer los grupos. Por favor, cada uno memorice cuál es su grupo para que después pueda ir a la estación respectiva. Grupo 1, Alejandro Salazar, Marcelo Ávila, Cristel Lutzinger, Nicole Plaza, Sebastián Villarreal, Orlando Páez, Luis Peña, Javier Matus, Pamela Suárez, Jorge Claro. Grupo 2, Betsabe Piña, Matías Chón, Mariela Brieva, Sofía Melani, Samuel Gac, Ruth Jiménez, Paula Herrera, Isis Gómez, María Domínguez, Felipe Elgueta. Grupo 3, Carla Inciarte, Pedro Forno, Sebastián López, Javiera Morales, Sebastián Cerda, Mauricio Acuña, Rodrigo Araya, Natalie Paderni, Carmen Barreto, Sergio Muñoz. Grupo 4, Stefano Samarín, Sebastián Garcés, Miguel Pacheco, Jorge Pérez, Zafiro Gil, Hernán Pasalacua, Irmari Blanco, Paulo Casí, María Villarroel, Maximiliano Miranda. Grupo 5, Edison Velázquez, Carla Parra, Pablo Famá, Antonio Vallejos, Nicolás Molina, Geraldo Cerda, Juan Francisco Alaman, María Paz Bachman, Nicolás Sidja, Muriel San Martín. Grupo 6, cualquier otra persona que no haya sido mencionada. El coffee break originalmente era de 30 minutos, en honor al atraso que llevamos con el curso, ha sido rebajado a 20 minutos, así que les pido que rápidamente vayan y engullan con velocidad el coffee break que hicimos con estándar Dr. Salaquet. Van a ver que es bien distinto al coffee break del Congreso Chileno de Radiología. Que lo disfruten y nos vamos a las estaciones prácticas después.